You're listening to the Cinemental Podcast.
Shall we begin?
Welcome back to the Cinemental Podcast, where we discuss mental health in cinema, television, and popular culture, and how it is portrayed. What did they get right? What did they get wrong? And what should you know about mental health? I'm Jeffrey Jones, and I'm a screenwriter as well as a professor of screenwriting, and I'm joined, as always, by my brother, America's psychiatrist, Dr. Joshua Jones, who, as well as being an unknown member of the Avengers, is also a general and forensic psychiatrist.
Yes, I thanks for outing me. Yeah.
We want you to start your week off right with our podcast. So we drop a new episode every Monday, and you're joining us now on Thursday because we do a second episode. We drop both those at 9 a.m. Eastern. You can listen to us wherever you get your podcasts, or you can watch our hottest and spiciest clips on YouTube. Today, we're continuing our conversation of The Pitt, the HBO show focusing on a day in the life of ER doctors at a poorly funded and staffed hospital in Pittsburgh, Pennsylvania. We talked a lot more about the show earlier in the week, and we want to dive a little bit deeper into some health topics. Mm-hmm. Josh, you want to tell us what those are, what we're going to cover?
Well, we're gonna talk about the American healthcare system, why the emergency department is such a good place to look at the failings and the challenges that come with the American healthcare system. And we're going to talk about how mental health emergencies are dealt with in the ER. Could it be done better? Is there a different way?
Okay, Josh, there's so much to cover when it comes to the healthcare system. You had said something last week. I want to touch on it again, and maybe this will springboard some conversation. But you had asked the question, and I think it's a great one. Why does it seem like we're poorly funded? Why does it seem like the healthcare system is poorly funded when we spend more on it than any other country?
Yeah. Well, we're spending the money in the wrong places, I think is one answer. It's not the whole story, but it's one answer. We have a tremendous amount of infrastructure, especially in the insurance area, that probably doesn't need to be there. This isn't necessarily the episode to talk about it, but you've certainly heard that insurance companies require physicians to get prior authorizations, most of which are unnecessary and probably don't drive better care, but it delays care, and it's a tremendous infrastructure that costs a lot. That's but one example about us not spending the money in the right place. Another thing, and I touched on this in the first episode, is that there's a significant amount of consumerism that we've baked into our healthcare system, that people can go get not necessarily the treatment that they need or is evidence-based or that will be good enough, but the treatment that they want. And a lot of that is driving healthcare costs up. We probably have an over-specialization in our country. That is, not enough general practitioners or primary care providers or pediatricians or even general psychiatrists or OBGYN providers, but more specialization that of specialized doctors that may or may not provide better care, may or may not provide better outcomes, but get paid a lot more for the high-priced procedures that they.
It's a specialty. It's simple, supply and demand.
And you hear these themes play out in the Pit. You hear that they may have actual physical beds upstairs in the hospital, and that's the dynamic that is you hear in most hospitals. The ER is on the ground floor, the rest of the hospital is above. That they have more beds upstairs, but they can't staff them either with nurses, or that specialists are holding on to the beds for cases that they want to bring up and not necessarily the ones that the emergency department wants to send up. There's a whole bunch of political interplay that goes on inside any hospital.
The political interplay is going to be there regardless. Right.
Sure.
Like even if we move to like a single payer system, the political side is going to be there.
Is
the answer moving to a single payer system?
I think yes, but only because the system that we have now appears so broken.
Right.
I think there's a lot of evidence that, at least we think that there's some evidence that other countries aren't super happy with their healthcare system. I don't think this generation of Americans would be at all happy with a single payer healthcare system. In 3 or 4 generations, once you're kind of used to getting some of the consumerism out of healthcare,
Right.
maybe.
So
I would say yes.
Do you say that because they don't get the immediacy that they want?
They don't get the immediacy, or they don't get the healthcare that they think they need. I mean,
Right.
We have a consumer healthcare market. You can advertise directly to consumers high-priced medications that may or may not provide slight percentages of better treatment than generic medications that are available cheaply now.
Right. Right. Yeah, you know me, Josh. I like things to be ridiculously and stupidly simple.
Yes.
One of the ways that I've sort of thought about it, researched, is the healthcare system profited $4 billion last year, and this might be a couple years old in terms of my stats, but the healthcare system profited as a business $4 billion, which means money was put in by people who want healthcare. And $4 billion of it just got erased. Just went to somebody else. Just went to corporations. That's $4 billion we could have spent on healthcare. And to me, that's as simple of an argument as you can make as to why, we shouldn't have, why this service should not be sold as a product. And that is the difference. It is a service and not a product. I can't put it any more simply than that. Like, we're paying in and not getting it back. And that's just wrong.
Mm-hmm. Yeah. And so why the emergency department is the place to look at this and to highlight this is because it's the place in the American healthcare system where they cannot turn anybody away.
Right.
They have to see everybody. And this is because of a federal law called EMTALA, EMTALA, that says that emergency departments must evaluate people who present to determine if they are having an emergency healthcare crisis or not. Right. Prior to EMTALA, emergency departments could actually turn people away if they couldn't pay.
That's ridiculous.
And now they can't.
Yeah.
And so you get scenes in the Pitt where it's a clog in the whole flow of patient care because they can't turn anybody away.
Right.
Nor would they want to. I mean, the people who are actually working there, the nurses, the doctors, the techs, they don't want to turn anybody away. Of course not. That's what they're there for. But they can't turn anybody away. So people get stuck there. They get boarded, and that's a term that you hear in the Pitt a lot, waiting for a bed to open up upstairs in that hospital or for a bed to open up in another hospital to get transferred to.
Right.
And so you will see emergency departments trying their best to take care of patients that should be in a well-functioning healthcare system, should be quickly transferred upstairs to a different place of care where they would be getting the standard of care.
Right. There was an interesting story I saw just on TikTok, and it's one of these things where, like, even if his story is not true, because anything you see on TikTok you got to take with a grain of salt. But like, I believe this one. But even if this one's not true, I do believe that something like this happened. But a guy was talking to his insurance company, and he had been billed $600 for an emergency or for a he had been billed $600 for an ambulance.
Sure.
Because he didn't have insurance. And then he provided his insurance, and he got a bill for $1,100. And he called his insurance company, and they're like, well, the actual bill was $2,500, and we took care of $1,400 of it. So you're actually, like, we paid a lot. And he's like, but why was it originally charged at $600? They're like, well, that was the discounted rate because you didn't have insurance. And he was like, well, can't I go back to that? And that is maddening. That is maddening.
Yeah. Yeah, so price transparency in the healthcare system is also massively broken. And there's been legislation in lots of different states to try to come up with more transparent pricing. But the simple truth is that our largest insurers in the country, Medicare and Medicaid pay below the cost to deliver that care. So Medicare and Medicaid, let's just say they pay 80 cents on the dollar. So you as a hospital spend $1,000 providing care to this person in terms of, paying your staff. You only get 800 back. So you've got 200 to make up. Where do you make that up? You make that up through commercial insurance.
Right.
And so you charge as much as you can get to commercial insurances to make up for the shortfall that you have in the governmental payers.
Okay, Josh, continue our conversation about the money. There is an interesting scene in the Pitt where the head of the hospital brings in a third party, and Noah Wyle, talks to this person who's a third party. You made an interesting point to me in our pre-meeting about where the power lies in hospitals and how it's been taken away from the doctor. So talk about that a little bit, about where we've gone awry, making healthcare a commodity, commoditizing it.
Yeah, so Noah Wyle asks this physician, did you go to medical school or did you go to business school? And he asks it kind of derisively, and she says both, stating, indicating that she both has her MD and her MBA. And physicians have lost a lot of power to direct the healthcare system by abrogating our responsibility to focus on the finances as well as healthcare. And Dr. Robbie, Noah Wyle's character, is kind of spun as this doc who doesn't care about the metrics and the money and the patient satisfaction scores. He just cares about getting care to patients. And that's only half the story anymore.
Right.
There's a saying when you're talking about how to fund healthcare that says no money, no mission. And that's absolutely true. If you can't pay your people to take care of patients, you can't run a hospital.
Right.
And I think some physicians have lost sight of that and say, no, it's just about taking care of patients. Yes, except it never was actually that simple. Even back before hospitals employed a lot of the physicians, you were in your private practice, and you couldn't pay your people if you weren't a savvy business person and you weren't able to, bill insurance companies correctly or collect the money that you need to make this go. Medicine has always been a business. Sure, it's a calling. Being a doctor is a calling, but medicine is a business. And even if we didn't consumerize it like we did, you still have to have enough money coming in to pay the people who are doing the work so that you have a healthcare system in the first place. And I think some physicians have lost sight of that you have to do both.
Right. And we have to get out of the mentality that I only want to pay what I need. I only want to pay for what I need.
Well, people don't want to pay for what they need. They want to pay the smallest amount, and they think that they're owed the rest of healthcare. I mean, I see this in mental health care all the time. People think, and some hospital administrators think mental health care should be provided for free. It just should be. You should just go out and see patients for no money, and it's weird. No, people don't want.
Why would anyone do that job then?
That's what I am saying to you. That somehow it should be a public utility. I actually think all of healthcare should be a public utility, not just mental health care. But that's just me.
I see. That's my point. Is I completely agree with that. Is it should be a public utility. It should just be something that we all agree everybody should have. I always go back to the I have a 100-person argument that I use all the time when I want to decide if something makes sense for a community. You imagine 100 people on a deserted island. It's obviously not deserted. There's 100 people there, but there's 100 people on an island. And what would society look like? And if there were 100 people on an island, if there was one or two doctors, the doctor would just be like, I'm willing to provide all the care that I need for everybody because everybody else is providing me coconuts and fish. Yep. And it just makes sense. We just give it, but there's an even trade. I don't think at any point that guy sits in his hut and is like, I'm not going to see that patient until I'm delivered 2 coconuts. it's not a business. It should be something that we all decide we want for each other. And it just comes down to, are you willing to pay for it? Are there going to be years where you don't need healthcare? Everybody needs healthcare, but you know what I mean? Like, I certainly, when I had my life-saving, not surgery, but when I had my blood clot, very happy to pay that year. There were other years where I haven't had a blood clot. Still happy to pay. Still happy to have a portion come out of whatever I earn so that other people can have healthcare. Still happy to pay whatever I earn so that someone who doesn't have a job can have healthcare. I'm happy to do it. And we just have to decide, are we happy to do that or not? And it just boggles my mind that people don't want healthcare for other people. It boggles my mind, Josh.
Jeff, I can't remember what age I was, but there was an age very, very young when I heard the phrase deserted island and thought that there was like ice cream sundaes and candy and, desserts.
That would be awesome.
Yeah.
We took my 3-year-old on a cruise over Christmas, and she cared about nothing other than the 24/7 ice cream machine.
That's all I care about right now.
That's what I'm saying. It's just life is so simple. It's like ice cream, ice cream. That's just great. Ice cream. I love it. Okay, so one of the interesting parts of the Pitt is when they're dealing with the Kraken. And the Kraken is somebody who's going through a mental health issue. Talk to me about that, and talk to me about how it relates to mental health in general in the ER, because we don't often think about mental health issues ending up with someone in the ER.
I think about that nonstop.
Okay, the layman, Josh, the normie, the non-psychiatrists, the non-dicks.
Well, when you say we, I'm thinking you and me, man.
Oh, that's fair.
Okay.
That's fair.
All right.
No, so I'm talking about we basic bitches.
Yeah. Right. You heard. Okay. All right. So the emergency department is the place to go for medical emergencies, and mental health emergencies are medical emergencies. That's where you go if you're having severe suicidal ideation, where you could be monitored and kept safe, and where you go if you've had a suicide attempt or a severe psychotic break, etc., etc. In the Pitt,
and that's what the Kraken has. He has a severe psychotic episode. Is that what that is?
Yeah, I think he's got schizophrenia. He's having a severe psychotic episode. I think they said it was methamphetamine induced, which is totally tracks. That was all very very realistic.
Right.
And they also said that he'd been boarding there for about a week, which unfortunately in our healthcare system.
It wasn't methamphetamine induced. It was just the fact that he was homeless and didn't have access to his meds because he didn't have insurance.
At one point, they said he was methamphetamine induced.
And then after he was okay, they were like, "Oh,
he said
yeah,
it just not with just didn't have my meds."
Yeah,
which is a very very common problem for our homeless folks who also have mental illness.
Right.
Where are you going to keep your medications? It's very challenging.
Yeah.
But with this guy, they also said that he was boarding there in the emergency department for a week or so,
right.
which is also unfortunately extremely common in the American healthcare system because there's not enough psychiatric beds in psychiatric hospitals or similar standalone psychiatric facilities to take care of the patients that they need. And in most states, they don't have to take a patient if they don't want to. So they could look at a guy like the Kraken and say, "Ooh, he's too violent. We're not going to take him." Wow. And you might be thinking to yourself, "Wait a minute, aren't you the specialized psychiatric hospital that should be able to do that?" Yes, and yet a lot of them don't.
So they'll just end up in prison.
No, they'll end up there in the emergency department for days and weeks.
Because the psychiatry department won't take them, and so they can't. The ER can't move them.
The ER can't move them. Exactly.
Gotcha. It's not that the ER will also dump them on the street. It's just that the psychiatry. Okay.
Yeah. And very realistic outcome of what happened here is they got enough psychiatric medications into him that he was able to calm down, recognize where he was, and come up with a plan to go back to his home, his homelessness, with medications delivered to him, and that was a pretty good plan. So is
that street team part? Is that they mentioned in the show? There's a street team that they have, and the street team goes out. That's a real thing.
Oh, absolutely. Lots
so
and lots
cool,
of
man.
Lots and lots of hospitals have teams like that, especially in urban areas. Many mental health departments in cities have teams called ACT teams, ACT, or Assertive Community Treatment, that will go out and treat people where they're at.
Sorry, spell act again. That was needlessly dickish on my part. That was needlessly dickish.
Wow.
Sometimes I just
Jesus
look for
Christ.
them, you know.
Yeah,
Sometimes I
no.
just look for them. Where can I get you?
You got me, Jeff. Give me the old 1-2. Oh.
Do they get special T-shirts though? Do they get to wear special T-shirts? Because I will sign up if I can be
for
part of
sure.
a street team.
For sure,
and
sure.
they give T-shirts. I'm
Yeah,
in.
and I had the fortune of getting to go out and do some of that work when I was a medical director of a community mental health center. We didn't have a specific ACT team, but we did act like outreach and did that out in the
You
community.
acted like act.
We sure did, Jeff.
You acted
we
like act.
sure,
And that's still spelled ACT, right?
We sure did. We sure did. Now, I will say, I have run into many emergency department physicians who are like, yep, it's great. We're here for everybody. I have also run into some who are like, I don't believe mental health belongs here. We're here for real emergencies. And that kind of stuff's got to go. That kind of attitude has to go.
Among fellow medical professionals.
I once approached the leader of the emergency department and said, hey, I'm the psychiatrist in town. I'd be happy to come and talk with your team about psychiatry. And I literally got waved off. I know psych, and walked away. And for 7 years, didn't have another conversation about it.
Wow.
Yeah. So that kind of stuff is out there too. I would say, by and large, the emergency doctors that I've met aren't like that. They're like, hey, all comers, we're going to do our best. We're going to just try to treat humanity as humanity comes to us. But like in other specialties, there's still some of that too, and we have to do better. I do think emergency departments could be designed for the new day and age, where behavioral health emergencies and urgencies are coming there, and more social emergencies are coming too. You saw in the Pitt, they were a huge emergency department.
Right.
One social worker.
Right.
That's probably very realistic as well.
Yeah.
A lot of rural emergency departments don't even have one.
Okay, you talk about expanding the ER, but you also were saying that, like, if we're going to change to a single payer system, we can't get in the habit of just going to the ER. We need to learn that not everything is an emergency. Bridge that gap for me.
I didn't say expanding the emergency department. I said designing it better, so that it's more, so that it's more attuned. It's a safer place. It's a less stimulating place for folks who are having mental health emergencies. Oftentimes, for safety reasons, and safety is trumping everything here, folks who have a mental health emergency in the emergency department get all their belongings taken away from them, get their clothes taken away from them, they get put in scrubs, and they get put on a gurney in a bare room. And that's in the name of safety. I'm not going to say that that's wrong for some patients. I am going to say that that's not right for every patient.
Right. That's really well said. Yeah. And how do you know that it's a mental health issue? Because the person having it, is it usually that the person coming in is like, I'm having a mental health crisis?
No. Frequently, it's a mystery. You're trying to figure out what's going on, because sometimes folks aren't able to. I mean, a very good example, and this is another great thing that the Pitt did. They had the one of the episodes. They had the influencer come in, and she, for all intents and purposes, looked like she was having a first break psychotic episode. And with diligent investigation, they found out that she was having mercury poisoning. It was pretty obvious to me with the portrayal that they had with some of the neurologic signs that it wasn't, and they also set it up in a dramatic way that it obviously wasn't going to be a psych case.
Sure.
Because Dr. Robbie said, oh, just send her to psych. And of course that...
Right.
We don't get them like that, but trying to figure out what's going on.
That's so funny. That's the doctor equivalent of when, I said it in a previous episode where someone's like, oh, here's one of the rules of this, but don't worry about it. It's like, well, that rule is going to be important later. It's kind of the doctor equivalent of like, just set it aside. It's like, oh, that's not going to be what the medicine ends up being.
So I was watching the latest episode of Reacher, season 3 with my son last night, and they panned to they panned across Neely, who's Reacher's friend. They panned across where she was just sitting, and they focused on her gun that she just left on her desk. And my son and I both look at each other and go, she's definitely not going to need that gun for this scene.
I mean, there's a term for that. It's Chekhov's gun. Have you seen Running Point yet?
No, my wife watched it, but I have not seen it yet.
Okay, so I love the fact that you love The Pitt because you're a doctor, and when you as a doctor, it's hard for you to watch doctor shows, and enjoy them.
Same as it is for you and I both to watch basketball shows, being two very tall basketball playing guys.
Right, sure, but that's why I bring up Running Point, because it's about basketball, and like the basketball is so bad that I can't enjoy that show. So I don't even know if it's well written or not. The basketball is just completely inaccurate. Like the owners getting involved in like personnel decisions, and it's like, no, that's the GM. The GM's job is to hire the team. The owner doesn't usually get involved with that. So like she was in the wrong here. And it's the stuff like that where I'm like, it's hard to watch stuff when you know more about the thing than the showrunners. And so I really think it's a credit to The Pitt, that even doctors are watching it and being like, oh yeah, it was a great show. Great show.
Well, sure, it's executive produced by a doctor.
Noah Wyle.
Hey.
Oh, I love that man. I love that man.
One
I'd love to meet
very
him.
realistic part of The Pitt is when they're talking about the Kraken, because the Kraken is obviously a derogatory name. And it's horrendously inappropriate to call your patients nicknames, especially psych patients. They call them
unless it's like Mr. Big Dick, or something.
Well, that's actually the point I'm about to make, Jeff, is that Noah Wyle says you shouldn't call him the Kraken, and she says, okay, it's Mr. Cracker Eyes. He's like, right. Really? He's like, really? He's like, it doesn't seem so bad now. So I'm like, okay, that is absolutely realistic.
Yeah, and that's a great joke too. Like that's a really well designed joke.
Yeah.
Yeah. So speaking about like how awesome Noah Wyle is, this is kind of my final thought. It's just a throwaway, but the dad of the son who ends up dying, and they do the march. Is a guy named
fentanyl overdose.
Is a guy named Brandon Keener. I used to represent Brandon, and I saw him every day because he would come in for voiceover stuff. He's the nicest freaking guy, and I'm just so happy every time I see him in stuff. And then the woman who plays the receptionist is a woman named Tracy Villar, and she's just a personal friend. Like she was going to be in one of my like unpaid shorts just out of the kindness of her heart. And it's just kind of nice to see like all these actors that I like really care about being in amazing projects, and getting to work next to Noah Wyle, which is one of my dreams now, because God, he's awesome. He's just awesome. Yeah. Such a good show.
Yeah.
Yeah. Is there anything you want to?
Yeah. The last thought that I'm going to leave you with, and I got to say, the other very realistic part about The Pitt are his flashbacks to COVID. Mm-hmm. COVID and the COVID years looms large over the medical profession still to this day.
Right.
And will for a while. I mean, the scenes of donning and doffing your protective gear, going in and out of the emergency department, that was very, very real.
Right.
And it was horrible. And I know some of my other colleagues, we sit on pins and needles waiting for the next one, the next pandemic, because it feels like it's going to come sooner, than this one did to the flu pandemic of 1918. It feels like we're just one wet bat sandwich away from 6 months later having another COVID, and it's terrifying because it was horrendously traumatic. And you talk about us in the medical profession not really processing the trauma. I'm not sure how many of us out there have really processed the trauma of those couple years.
Yeah, and it's really a shame too that that really, really good people were doing incredibly dedicated work while people were just denying it. With how full ERs were, and people were just denying that ERs were full at all. And it's like, guys, there's video evidence everywhere. Like this is just, the whole thing is ridiculous.
And
but
it didn't start that way. It didn't start that way. If you remember back to the start of COVID, those first few months, those first couple, 3 months, people really did come together, but that disintegrated fast.
Yeah. Yeah, I mean, we used to come together for these things. That actually, it just brings me to a quick moment I want to mention, and then we can get out of here. I loved in episode 9, there was a fight that 2 patients had in the lobby. And, one of the patients was asking the person to put on a mask. And I don't know if they were right in doing that, but they made the other person obviously an anti-vaxxer, mask, hated Fauci, all those things. And they bring her back for surgery. And the doctor says, oh, hey, it's really your choice. Do you want the doctors who are going to be operating on you, do you want them to be wearing a mask? Because I know you're against masks, and so I'll leave it up to you as if you want the doctors who are operating to be wearing masks. And she says, yeah. I thought that was a great moment, because I think that most people who are anti-mask would probably say the same thing in that moment. And it's like, yeah, think about it. Think about it for just a hot second. Masks obviously block. It's just an obstacle. It's an obstacle. Of course it blocks stuff. Like, what? What are we talking about? It's like, I have a little bit of empathy for flat earthers, even though it's really dumb, because, like, we can't see the ends of the earth, But it's an obstacle. You can see it. It's right in front of your face. It's right under your nose. I mean, it shouldn't be. It should be over your nose. But, like, it's right there. The whole thing is so lunacy to me.
During the COVID years, I was the chief, as you know. I was the chief over an outpatient clinic system up where I live, and I got to deal with lots and lots of people who were resistant to wearing masks, didn't want to wear masks in the clinic, etc. I had one really great success early on. It was one of the only successes I had, where this gentleman who I knew a little bit, I'd seen around town, refused to wear a mask, and he actually had it around his neck. He's just like, I'm done with this, I'm not going to wear more. So I got set to talk to him, and I knew a little bit about his politics, and he's like, I'm just not wearing this. I'm going to start wearing this, doc. I was like, okay, that's fine. Yeah, at that time, you actually didn't have to. I said, that's fine, but I don't understand why you would give up the best way to foil the government's facial recognition system. And he just looked at me, locked eye contact, and slid the mask up over his nose. And then when I'd see him around town every few months, just walking by, and every time he'd see me, he'd look at me and he'd just go like this.
That's amazing. And what's great about that moment is that, like, you knew exactly how to act. And that is still spelled ACT. Okay, thanks as always for watching or listening to Cinemental and our continuing coverage of The Pitt. If you like this episode, please subscribe anywhere you get your podcasts. You can also watch clips of Cinemental on YouTube, where we'd love to hear what you'd like us to cover next. You can also watch my companion series, The One Thing, where I take a deeper dive into screenwriting, not doing that whole thing over again. Both are available on the Large and in Charge channel on YouTube. Follow Dr. Josh Jones, America's Psychiatrist, on Blue Sky. This has been a Large and in Charge production. For Josh Jones, I am Jeff Jones, and we will see you next week.
I want you to hit me as hard as you can.